today my task is colorectal cancer screening, and this is my objectives. Why colorectal cancer screening? What are the type of screening available, and what are the available tests? And we'll go quickly on the Dubai Health Authority guidelines for colorectal cancer screening. So as Dr. Samir said, March is the Colorectal Cancer Awareness Month, saying that March is the awareness month. We should not focus only on March. So we have to screen our patients throughout the whole year. So we don't want to see our patient with such advanced colon cancer, where the management will be really very poor for those patients. So prevention, always we speak about prevention. Prevention is better than cure, always. And in Arabic, we say, درهم وقاية خير من قنطار علاج, meaning that spending 1 dirham in preventing disease or vaccinating disease, for example, will prevent better than spending thousands of dirham in curing or treating the disease. So we can fight colorectal cancer hardly and strongly. And the top 10 barriers, the most common causes of the top barriers for screening, more than 50% who never screened because they didn't have any recommendation from any doctors. So this is one of the things that we have to keep it in our mind whenever we see a patient who is eligible for screening. So if you will see the adenoma carcinoma sequence, when you have a normal colon, in the presence of the genetic, environmental, and lifestyle factors, and then you will have a polyp, and this polyp can turn to be cancer. Now we see from the National Polyp Study up to 90% reduction in the cancer incidence after polypectomy. The beauty of this sequence will take up to 10 years in most of the people. So this means that we have time for screening of our patients, and if there is any polyps, we can survey them elegantly over the years. So this is one of our patients. You can see that the polyp looks a bit ugly from the bed pattern, from the nodularity, from the surface, from the vascularity of this polyp. Although it is small, approximately 1 centimeter, but looks ugly to me. And then after lifting it and then removing it with the snare, you can see that this polyp turned to be adenocarcinoma, and the whole resected margin was free from any invasions. So this is the beauty of the colonoscopy and polypectomy. So if you see in the United States, there is a reduction in the incidence and mortality in both male and female, and that's because of the screening. You can see that the more screening, the better reductions of the incidence and mortality in colorectal cancer. If you will see in the Saudi Arabia, for example, you can see that the incidence is slightly increasing, and in the United States is decreasing, and that's because of the colorectal cancer screening programs. So what are the available tests for the screening? We have the stool-based test, we have the guaiac FOBT, which should be done yearly, FIT, and we have the FIT DNA, and then we have the blood-based test, which is the Septin9, and then we have the direct visualization, non-invasive, like the CT coronography or colon capsule endoscopy, and we have the invasive tests like colonoscopy and FlexEgg. Now, the US Multi-Society Task Force in 2017 came with Tier 1, Tier 2, and Tier 3, and you can see that Tier 1 is the colonoscopy every 10 years, and then annual FIT for fecal immunochemical tests, and then Tier 2 is the CT coronography every 5 years, and then the fecal DNA every 3 years, and then FlexEgg every 5 years. And then Tier 3 is the capsule colonoscopy, and the Septin9 is still, the evidence is poor. Now, the guaiac FOBT is indirect biomarkers, colorimetric detection of peroxide activity, guaiac resin in the presence of hemoglobin, and H2O2 will give you blue color. And there are huge, very well done studies with huge number of patients show that colorectal cancer mortality have been reduced significantly with guaiac FOBT. You can see here in US study 46, Denmark 61, and 150,000 UK. And you can see follow-up 13 years with annual 33% reductions of mortality. And that's because of two-step guaiac FOBT and then colonoscopy if it's positive. And then every 2 years, there is a reduction again with 21%. So the evidence is very strong with guaiac FOBT. But the problem is the guaiac FOBT is the sample instruction. You can see that you have to avoid NSAID for 7 days, avoid for 3 days the vitamin C, citrus fruit juices, red meat, and you have to eat a balanced diet, including fiber, fruits, and veg. And you need to collect the sample of 3 different days, collect it in the toilet water, and return it within 14 days. So all these things makes the guaiac FOBT very difficult. Although the advantage is the evidence, it showed evidence that it reduced the mortality and the incidence, but the problem is the dietary modifications. So that's why FIT took over the stool test in terms of the sensitivity and specificity. You can see that to evaluate the occult blood test in the stool, detect globulin proteins, hemoglobin molecules, and uses antibody directly to test human hemoglobin in the stool. It does not require data modification, which is the beauty of the FIT, more accurate than guaiac FOBT, and must be done annually. So if you see the accuracy of fecal immunochemical test for colorectal cancer, this is a systemic review and meta-analysis. You can see the sensitivity is 79% and the specificity is 94%. Now, if you will compare the guaiac FOBT versus FIT, the specificity is almost the same, but sensitivity for colon cancer, 33 versus 73, and for advanced neoplasm, 8% versus 25%. Not only this, but FIT also more attendance and more engagement of the population, which is really, when you are doing the colorectal cancer screening, that's what you need, rather than only the test. So you need more population, and FIT is where you will engage more populations. So the FIT it's cheap test, and the disadvantage is that not good for detecting serrated polyp or flat polyps. And of course, it is two-step test where if it is positive, you need to go for colonoscopy. Now, the multi-target DNA came, it is approved in 2017. It has 3 components. The sensitivity is 92% for colon cancer, and for polyp, more than 1 centimeter, sensitivity 42, and the specificity is 87%. Now, if you will compare the stool DNA versus the FIT, you can see that the sensitivity is better with DNA, 92 versus 73, while the specificity is better with FIT, 94% versus 86%. The problem of the stool DNA is the cost. CT colonography is similar to colonoscopy by visualizing the entire colon mucosa, but does not require sedations, requires bowel preparations. A small tube is passed in the rectum with CO2 air insufflations, with volume pressure regulations. The colonic image will be taken in 2 dimensions to 3 dimensions and use low dose of radiations. The main indication is incomplete colonoscopy for screening or surveillance, or FIT positive patients who are refusing to go for colonoscopy. The contraindication for CT colonography is intestinal obstruction, suspected peritonitis, recent abdominal surgery, pregnancy, and iodinated contrast allergy. So these are the picture of the 3D and the 2D you can see, and the sensitivity of the CT colonography is 93% for polyp more than 10 millimeter, but it is less for the smaller polyp. Not only this, but also there is a missing of the flat and serrated polyps. Again, 2,500 asymptomatic subjects, the sensitivity showed 90% for polyp more than 1 centimeter. The beauty of the CT colonography sensitivity, as I said, more than 90% for 1 centimeter polyp, non-invasive with 5 years performance interval, and can be performed safely in anticoagulate patient. The disadvantage, poor detection of small or flat polyp or serrated polyp. There is a radiations, which is low air inflation and poorly diagnostic, and also the extra chronic finding, which is sometimes advantage or disadvantage. So this is not pictures of colonoscopy. This is colon capsule endoscopy. This is the second generation of the colon capsule endoscopy. You can see that there is dramatic improvement in the imaging, and the colon capsule endoscopy have been approved by the FDA. And you can see that adaptive frame rate takes imaging at a rate of 40 to 35 frame per second, and it is hibernated while the capsule passes through the small intestine in order to capture the colon mainly. So if you see the accuracy of colon capsule endoscopy for detection of polyps, systemic review, and meta-analysis, you can see that the second generations did well. Polyp more than 1 centimeter, 87 sensitivity, while the specificity is 95%. So the accuracy of colon capsule second generation favorable comparable to the CT colonography. So the capsule colonoscopy limitations is more, and you need more bowel preparation, which is sometimes more than 4 liters of bag solutions. Additional laxative prokinetic sometimes needed. The technical failure is there. 9% in the US study showed the rapid transit. And of course, one of the main problem is the poor bowel preparation, which is limiting the sensitivity of the capsule colon endoscopy. Colonoscopy is the gold standards because it is prevention and detection and removal, and that's not present in the stool-based test or the other test. This is another patient. You can see it looks again ugly polyp, which is approximately 1 centimeters. And again, after lifting it and removing it completely, it turned to be adenocarcinoma. So this is the again the beauty of the colonoscopy in removing those precursors of cancer. So one of the eminent study or important study showed us in the 2013, and the colonoscopy, polypectomy, and long-term prevention of colon cancer death. We saw from this elegant study that there is a 53% reduction of death from colorectal cancer from colonoscopy and polypectomy. So all roads takes you to Rome, and all paths or roads takes you to colonoscopy, whether it is stool test, whether it is imaging, capsule, or CT colonography, or FlexEgg, or whatever test, all the way takes you to colonoscopy. And if you see that if there's increased adenoma detection sets, increasing the adenoma detection sets lower the mortality and reduce the healthcare cost. If you see the colon cancer in the United States costs around $300,000 US dollar per patient, and if you have 1% increase in adenoma detection rate, there is 3% reduction in the interval of colorectal cancer risk, and there's 5% reductions in the risk of fatal interval cancer. There's challenges in the colonoscopy, yes, but with quality colonoscopy, we can do excellent job. So screening programs, we have the opportunistic screening program, and we have the organized screening programs. We have the opportunistic, which is there is no any invitations in the system, and there is no any control for any steps. The IT system and data are missing, and there is no any registry. While the organized screening program, there is specified age, specific age, there is screening methods, and there is interval for each step. There is defined target population. There is organization responsible for the implementation, taking care, and follow-up. Not only this also, but there is a quality assurance and monitoring. There is IT system, data, and there is cancer registry. All these things are present in the program. So the other importance of the program of colorectal cancer screening program is the greater detection against harm. So we can avoid overscreening, poor quality, poor follow-up, and also will minimize the complications. The screening is a process, so it is not only one test. So you need to identify, invite, assess the risk, screen, and then notify the patient, follow up, remind, and follow up. So all these things are not only one shot, one test. You need to have the process and you need to evaluate each step elegantly. So we went in our Dubai Health Authority from 2012 to 2016. In our registry, we found that the colorectal cancer ranked the third, and we can see that the highest cluster of cases are between the age 55 and 59, and the median age is 56. So we went to 45 to start our colorectal cancer screening in Dubai Health Authority. Now, if you see in Saudi Arabia, which is not far away from us, you can see the median age is 58. And in the United States, 68 and 72 in the United Kingdom. So the inclusion criteria of Dubai Health colorectal cancer screening, asymptomatic adult, the average, the age between 45 to 75. Between 78, we recommend against routine screening. We need to take them case by case. The exclusion criteria above the 86, or if there is a severe comorbidities. High-risk patients, those who are above 50, male, family history, or smokers or obese, all these are high risk, and they should go straight forward for colonoscopy rather than going for FIT. And the most important question, whether to go FIT and then for colonoscopy or to go for colonoscopy. And you can see that colonoscopy is straightforward, more invasive, yes, high risk, but more cancer prevention. While a FIT, less invasive, fewer colonoscopy, less cancer prevention. So this is the pathway of Dubai Health Authority for colorectal cancer. You can see that after the age from 45 to 75, pre-screening, education, and counseling by the general practitioners or the attending physicians. If he is high risk, then he will go for straight for colonoscopy. If average risk, again, we recommend for colonoscopy, and that's what we prefer. But if the patient is refusing, we go for FIT. If negative, annually. If FIT positive, then we go for colonoscopy. If the colonoscopy is incomplete, then he will go for CT colonography. So the colon cancer screening quality indicator for colonoscopy, and that's what we took it in our DHA, informed consent and education for the patient of the complication and all these things. The quality of the bowel preparations and preparing the patient elegantly. Withdrawal time should be measured also, and the sequence intubation. All these key performances have been taken. And the second step is to take the adenoma detection rate, the bowel removal, the polyp removal, and the adherence to surveillance. There is limitation for colonoscopy, the invasiveness, limited colonoscopy capacity, economic burden, and the variable colonoscopy quality. Dr. Ammar is going to speak about the quality in colonoscopy, but what I want to point is the effectiveness. Effectiveness is not only quality, but also more participation to the program. So this is my take-home message. Screening is effective in reducing colorectal cancer incidence and mortality. All individuals between 45 to 75 should go for colorectal cancer screening. Colonoscopy is the gold standard in colon cancer. It is the preferred test, and it is number one for us. The patient refusing colonoscopy should go for FIT. CT colonography and capsule endoscopy for FIT positive, and patient refusing for colonoscopy or incomplete colonoscopy. Thank you.